So the type of hip condition that would require a hip replacement, it really is several things. You have to not only demonstrate arthritis, but you have to be symptomatic as well. And that means it has to bother you every day, and it has to change fundamentally who you are. So if it's not doing those things, I say to a patient, I'm not going to operate on the every Tuesday hip. I'm going to operate on the every day, this is slowing me down hip. It's very helpful, for instance, to come in with family members because they're going to notice things that the patient may not. And then the other parts of it that have to match, the physical exam, of course, has to match. They have to have limitations on that. But we also have to see radiographic evidence. And if we don't see that radiographic evidence, well, then we have to look further. And what else could this be? Do we need to do advanced studies, such as an MRI, for instance? The hardware and different approaches to hip replacement. Approach is a term that we throw around, and I tell patients airline pilots use the same word, approach. It's determined by safety corridors. For them, it's wind and traffic patterns. For us, it is more based on safety corridors with nerves and vessels. So several different approaches of the hip have been described. Really, they're much older than people think. I use a direct anterior approach, which has been around since 1890. And it's how do we get in? And using my hand in this model, you basically come in at various angles relative to this half a pelvis right here, and this is a femur model. And a direct anterior comes in a little off, not directly anterior because you have nerves and vessels here, but about this angle. Then you have an anterior lateral approach right here. You have a direct lateral approach, which comes in, as the name would suggest, laterally. And then you have a posterior lateral approach. And medial approaches have been described a little bit in the pediatric literature, but for joint replacement, those ones I mentioned are the main ones. I choose the anterior approach for its benefits. I get to use fluoroscopy during the case, very low energy x-ray, so I get to put your implant exactly where it needs to be. I get that instant feedback. I don't have to use surrogate measurements throughout the case. I can actually look at your film, and I look at the final product before you leave the operating room, so that's a huge advantage. The case itself takes about an hour of actual surgical time. You're in the room for anywhere from an hour to an hour and a half, depending on different things about your case in particular, but we're able to do almost all of that. We do not use a special table at our institution. We use a regular surgical table, and we're able to gain the exposure into the various anatomical parts of the hip. The time afterwards, you'll go to the recovery room. The hip's been back in place. It's now functioning just like a normal native hip. And we have a dressing in place, and we take you to the recovery area, which you're there for an hour to a few hours. And before you're sitting up, and then before you leave the building, we have to ensure certain benchmarks are met, such as being able to have your pain controlled, go to the bathroom, have your sensation back, etc. We usually use what's called neuraxial anesthesia, where we use a spinal anesthetic because it provides us excellent blood pressure control, excellent pain control, clot prevention, and all of those combine to really make it a good experience, but we have to wait until you're able to walk and bear weight safely on it. Then afterwards, you get home, we have you bear weight on it immediately, and after a few days, we hope that you are moving around the house, not getting over aggressive. There's no need to take 16 laps around your neighborhood, and that you just add a little bit every day, knowing that some days are going to be sore, some days are not going to be sore, and you're going to build on that. And most of us in our group, myself included, do not usually use post-operative physical therapy. We just have you walk. Certain cases I will, if you have some special things like you're cane dependent, walker dependent, have other conditions affecting your back, for instance, I may incorporate physical therapy, but usually it does quite well. And then we just add a little bit more every week until we see you at about 5 weeks, 6 weeks out from surgery.